In November 2017, a 65-year-old woman was referred to my clinic for a concern of a new diagnosis of AML. And so on presentation to me, she did have a diagnosis of AML confirmed. She had diploid cytogenetics, and a molecular panel was performed. And on that panel, she had a IDH2 mutation, a R140 mutation, as well as a DNMT3A and RUNX1 mutation. She was 65, and induction therapy was initiated for her, so she received standard 7+3 chemotherapy. And this was complicated by fairly mild mucositis, a neutropenic fever or two. Overall, she tolerated it well, though, and recovered in a remission, thankfully. And she went on to receive 2 high-dose cytarabine consolidation therapies. And after recovery from her induction therapy, her counts normalized, she was doing well, and she went on to receive 2 additional courses of high-dose cytarabine consolidation. In May 2018, about 6 months or so after her initial diagnosis of AML and remission, thereafter, her count started to drop, some cytopenias and just some nonspecific aches, fatigue, and a repeat bone marrow was done, and it did identify, unfortunately, relapse disease. Again, with diploid cytogenetics and similar molecular phenotype, so the IDH2, DNMT3A, and RUNX1 mutations again identified. One of the most important things to decide when you have a new patient with AML is the treatment regimen. So treatment is typically either intensive therapy or non-intensive chemotherapy options. And in a 65-year-old woman, she could be appropriate for either. And so you want to base that decision based on patient-specific characteristics, such as their fitness, other medical comorbidities, as well as leukemia characteristics, things like their genomic profile and antecedent hematologic disorders, secondary AMLs, things of that sort. And so she was fit, and so she received a more standard intensive chemotherapy regimen.